Bridgette Finley initially believed that the almost daily headaches she was experiencing were migraines with aura. She said, "These migraines would make me physically sick, lose my vision for small windows of time, were accompanied by intense eye pressure, and would at times make me feel as though I was going to pass out." She obtained significant relief when she was treated with topiramate, but the headaches came back when she had to stop the treatment during pregnancy. She said her headaches became unbearable, associated with a loud pulsatile tinnitus that she said was like a heartbeat or the ocean. The headaches impaired her ability to carry out even the simplest daily tasks, and her nights became an endless struggle against sleeplessness. She endured a bewildering array of other symptoms, from brain fog, pressure in the eyes and neck stiffness, to dizziness, loss of balance, and speech difficulty. She also said that her symptoms worsened with sneezing, bending over, and even going to the bathroom. More worryingly, she then started leaking fluid from her nose, her eyes, and her ears. Serendipitously, her husband's friend advised that she have her eyes examined. And it was this assessment that revealed what she called pressure on the optic nerve, a sign of raised intracranial pressure. Finley had been enduring the travails of idiopathic intracranial hypertension, or IIH, and she was narrating her story in the memoir titled "Hank in My Head: Embracing Life Through Overcoming the Challenges of IIH." Hello, I'm Ibrahim Imam, and welcome to another episode of the Neurology Lounge podcast titled "Crisis: The Predicament of IIH." Pebbles Wireman was another person who wrote of her suffering with IIH in her book titled "Finding Faith in the Storm," a memoir. Wireman described how she developed headaches after she endured 2 severe traumatic brain injuries. Just like Finley, her headaches were migraine-type headaches, and they steadily worsened and started manifesting on most days of the week. As the headaches progressed, she said, "My head becomes lost in an illusion of a battle that has left me defeated." One day, she wrote, "A migraine attacked me like a lion, leaving me lifeless. The right side of my body became paralyzed and my eyesight blurred." And on another occasion, she said, "I woke up at 2 a.m. with a migraine that blinded me in my right eye and left me motionless." This was when an ophthalmologist examined her. She wrote that over the course of 2 hours, he ran several tests, which she said revealed swelling of my optic nerve and a narrowed vision field. Just like in Finley's case, it was the discovery on eye testing that led to a neurologist to perform a lumbar puncture and to diagnose her with pseudotumor cerebri, just an old name for IIH. Pseudotumor cerebri is a moniker that highlights the similarities between the manifestations of IIH and of brain tumors. Both tumors and IIH can cause raised intracranial pressure, but in IIH there is no structural cause for the increased pressure. As an aside, IIH also used to be called benign intracranial hypertension, but the potential consequences of the raised pressure, such as causing blindness, necessitate dropping the term benign from the name. Benign was then replaced with the term idiopathic, and this emphasized the absence of a clear cause for the raised pressure in almost all cases. The diagnosis of IIH is supported by a raised opening pressure at lumbar puncture, but this is not always the case. This was the situation with Elise Goetzinger, who narrated her illness story in the memoir titled Pincushion. Goetzinger traced the onset of her illness to birth control injections she was administered when she was about the age of 13, and these were meant to control what she called her awful periods. She first noticed increasing forgetfulness, followed by recurrent episodes of throbbing headaches, sudden but transient visual loss, and collapsing to the ground. On one occasion, she developed what she said were huge black pupils consuming all the blue in my eyes, associated with numbness down her right side. After all routine assessments at the hospital were normal, she said the doctors tried a bedside blind lumbar puncture. And whilst this showed a high CSF opening pressure of 22, she was told nothing was wrong with her because the fluid was clear and only a pressure greater than 30 was considered high. Her headaches nevertheless improved after the spinal tap, making her seek another lumbar puncture. And this time the pressure was measured at 35. It was therefore only after a second spinal tap that Goetzinger was diagnosed with idiopathic intracranial hypertension. As we have seen in the cases of Finley, Wireman, and Goetzinger, the most frequent symptom of IIH is headache, and this is present in more than 90% of cases. The headache is frequently migraine-like, and it may be described as pressing or explosive. The headache may, however, manifest as other headache disorders, even such as cluster headache. The headache in IIH may be associated with other headaches such as tension type and medication overuse headache, so it might be difficult to tease out. Let us take a little detour here to trace the history of our understanding of intracranial hypertension, and our guide will be the book titled The Silent Pressure Within, written by Christopher Blessing. In his account, Blessing credited Jean-Louis Paul Duret for coming up with the term intracranial hypertension in 1824, and he used this to describe the clinical manifestations of raised pressure in the brain. But it was not until the mid-1900s that Blessing said lumbar puncture was introduced as a diagnostic tool as well as a form of treatment for intracranial hypertension. The spinal tap or lumbar puncture is an essential assessment for IIH for two main reasons. The first is that it enables the exact measurement of the intracranial pressure, called the opening pressure. A pressure of 10 to 20 millimeters is considered normal, 20 to 25 is borderline, and greater than 25 is high. In most cases of IIH, the pressure is greater than 30. You can now see why Goetzinger's doctors erroneously dismissed her opening pressure of 22. Finley, Wireman, and Goetzinger all experienced relief from their headache after their spinal taps. However, headache relief after a spinal tap is an unreliable indicator of IIH, as people with other causes of headache may experience similar relief after the procedure. Furthermore, only about 20% of people with IIH experience relief of their headaches after a spinal tap. Worse still, the improvement in headache is very transient. Indeed, Finley wrote that, sadly, the relief I felt lasted no longer than 3 hours, and all my symptoms came back like a flood. This is why repeated spinal taps are no longer considered conventional treatments for IIH unless as a temporary measure whilst awaiting definitive surgery. Beyond headaches, a more suggestive symptom of raised intracranial pressure is when the vision repeatedly becomes blurred for a few seconds. This is called visual obscurations. Other visual symptoms of IIH are photophobia or light sensitivity, loss of vision in parts of the visual field, and even permanent blindness. People with IIH may also develop nausea, vomiting, dizziness, double vision, and impairment of the sense of smell. In Goetzinger's case, she lost 75% of her hearing as a complication of IIH. Nothing benign about it. And on clinical examination, the most important sign, as we have seen, is papilledema or swelling of the optic nerve head. This is seen as blurring of the margins of the optic nerve head in the back of the eye when examined with an ophthalmoscope. Confusingly, this may only be present on one side, or it may differ in severity between the two sides. And importantly, it is not present in about 6% of cases. This is called IIH without papilledema, a trap for the unwary and even the wary. Examination of the eyes may also show an enlarged blind spot, and it may show degeneration of the optic nerve and, of course, visual field defects. Although there is no cause for IIH, there is a host of recognized risk factors. And the major risk factor is obesity, usually in females in their childbearing years. IIH, however, can manifest in men and in children. It is also relevant that IIH occurs more often than expected in people with the polycystic ovary syndrome, diabetes, hypertension, obstructive sleep apnea, ischemic heart disease, and stroke. Several types of brain scans are required in people suspected of having IIH. These may show the typical features of IIH, but more importantly, they ensure that there are no structural causes for the raised intracranial pressure, and these are things like brain tumors, infections, and clots in the veins. An MRI scan of the brain is the usual scan of first choice, and like all the accounts we have come across in this podcast so far, shows no causative abnormalities to account for the pressure. The MRI, however, may show clues to the diagnosis of IIH, and amongst these are an empty cellar. This is the snug cup-like structure below the brain that houses the pituitary gland. The height of the pituitary itself might also be reduced in IIH due to the pressure. The MRI may also show changes in the orbit, such as flattening of the back of the eye globes, protrusion of the optic nerve head, enlargement of the optic nerve sheath, or tortuosity of the optic nerve. Quite a few clues. Other possible MRI findings are descent of the lower end of the cerebellum, called tonsillar herniation, and outpouchings of the coverings of the brain or meninges, called encephalocele and meningocele, respectively. While still on brain imaging for IIH, one of the scans that is essential is called a venogram, either done with an MRI or a CT scan. This is an invaluable test as it may detect abnormalities in the veins of the brain in people with this condition. These abnormalities include thinning or narrowing of the venous sinuses, especially the transverse sinus. Another investigation that measures the intracranial pressure more accurately than a lumbar puncture is the insertion of an intracranial pressure monitoring bolt. Yes, bolt. This was a procedure that Goetzinger underwent, and she described this as a procedure where they drill into the skull and insert a catheter to measure CSF pressure for 48 to 72 hours. She wrote that once the bolt was in place, they noticed that when I was lying down, the pressure was 25 to 40, but when I stood up, it spiked to 60 to 100. Although a brain scan can exclude a structural cause of raised intracranial pressure, it is important to realize that the pressure can become elevated non-structurally in cases that are not IIH. And amongst these non-structural causes are the use of several antibiotics, such as tetracycline, doxycycline, minocycline, sulfonamides, nalidixic acid, and iprofloxacin. Raised levels of such hormones as growth hormone and thyroxine may also do the same, as may hormone therapy during gender change. Other medications that can mimic IIH are tamoxifen, anabolic steroids, lithium, mycophenolate, and vitamin A toxicity. The conservative management of IIH rests on weight loss by dietary restriction and exercise. This is usually combined with the use of diuretics or water tablets to help to drain the fluid in the CSF. Finley and Goetzinger, for example, were respectively prescribed acetazolamide, the water tablet of choice, and topiramate. In recent years, there have been encouraging reports of the value of other oral medications called GLP-1 receptor agonists, but these are still early days. Oral medications are, however, often just temporary measures for IIH until a definitive treatment is implemented or weight loss is achieved. In Finley's case, she went on to have venous sinus stenting. This is a procedure that is used when the venogram scan shows narrowing of the venous sinuses, seen in some people with IIH. Finley wrote that once a stent was placed, it opened up the blocked area and helped relieve the symptoms. She wrote of how her brain fog, fatigue, and pulsatile tinnitus vanished into the quietude of memory. More commonly, the surgical treatment for IIH is the insertion of a shunt or a tube to drain the cerebrospinal fluid from the brain into the abdominal cavity, from where the body kicks it out. This is illustrated by Goetzinger's case, who first had a ventriculoperitoneal or VP shunt. Her post-operative course was, however, pockmarked by complications such as blocked or broken shunts, and this required countless shunt revisions by countless neurosurgeons. This is sadly a common scenario after the insertion of shunts. Goetzinger then had a lumboperitoneal shunt, but this was also plagued by complications from breakdown of sutures to shunt breakage and infection, again requiring multiple shunt revisions. And when an attempt was made to remove her old catheter, she suffered a bleed in the brain. Another surgical approach is optic nerve sheath fenestration, or ONSF, which was considered for Goetzinger but not carried out. Unfortunately, even after the intracranial pressure normalizes in IIH, patients may go on to experience post-IIH headache. You can't win. This may be difficult to control, but the CGRP monoclonal antibodies used to treat migraine may be helpful in this condition. The long-term clinical course of IIH is a very bumpy one indeed, and this is again portrayed by Goetzinger. She wrote, for example, of how her childhood was enveloped in hospital rooms. This is because she required 26 different operations during her long suffering with IIH. Such is the checkered course of IIH. Thank you very much for watching or listening to this podcast. If you found it enlightening, why not click on the like button, or better still, subscribe to the YouTube or Spotify channels of the podcast so that you don't miss the next episode. And whilst waiting for that, why not check out my book called Surfing the Brain, and check my website called Neuro Checklist. Thank you very much for your time.